Hello, everyone. Good afternoon. On behalf of the Systems for Action National Coordinating Center, my name is CB Mamaril, and I'd like to welcome everyone to today's Research in Progress webinar. We have an exciting topic this day for our webinar on the network view of population health delivery systems. Before I begin, I would like to acknowledge the funding and support of the Robert Wood Johnson Foundation. So it is my pleasure and privilege to introduce our presenter for today, Dr. Rachel Hogg Graham. Rachel is an assistant professor in the University of Kentucky College of Health Sciences, Department of Human Health Sciences. Rachel's research focuses on public health system organization and composition and the integration of public health and healthcare delivery systems. She has published several peer-reviewed articles and is currently funded by Academy Health and the Robert Wood Johnson Foundation. Before joining the faculty in 2015, Dr. Graham completed a postdoctoral fellowship at the University of Colorado Denver School of Public Affairs. Rachel earned her doctorate of public health and health services management and her MA in history, specializing in the history of health and medicine, both at the University of Kentucky. So with that, I'd like to turn it over to you, Rachel.
Great. Thank you so much, CB, and thank you to everybody that's logged on today. I know it's a quite hectic time of year, and it can be difficult to find extra time in your day, but myself and also the National Coordinating Center really appreciate you guys being here, because today I'm going to talk to you all a little bit about some work that we're doing as a part of the Systems for Action Center intramural research team, and specifically kind of trying to look at and determine some of those cross-sector relationships that we know are increasingly important and going on in the system. So as I mentioned, we've got that push for cross-sector collaboration. So there's a growing number of national initiatives that call for public health, social service systems, and traditional healthcare providers like hospitals and physicians organizations to stop working in their silos and really come together to meet the unique needs of the populations that they're trying to serve. So just a few examples of what's going on out there. We have the IRS requirements for nonprofit hospitals. Along with the public health accreditation efforts, there's a large push for collaboration. We have accountable care organizations, patient-centered medical homes, and the CMS accountable health communities. And really, these all represent that effort to come together, but also a push more toward value-based care rather than monetary-based care. So what's that created? It's created this population health network with a lot of different people participating and working on services and trying to come together. But the system is still really squishy, and that's something at the Systems for Action National Coordinating Center that we're trying to figure out what exactly it looks like, what drives these partnerships, what makes them change over time, what exactly does a relationship look like, how are they working together, is it very basic, is it very intensive, are they just sitting on boards together, are they really participating in the provision of services together? What defines a successful partnership? So that's something that I've worked on during my postdoc and now to really think about what makes partnerships high quality and what helps them sustain over time. And then ultimately, what impact does collaboration really have on health outcomes? So how do cross-sector partnerships make the community better and healthier? So how do we look at these partnerships and think about their evolution and the impact that they have on health outcomes? Well, one thing that we think is really important in doing this is using social network analysis. So social network analysis is a set of methods that lets researchers really examine the interactions among, within, and between organizations that are participating in population health. And understanding that structure and composition of the network might help us understand the effectiveness and efficiency of these activities in the ways that they're delivered into the surrounding community. So one thing that we think is really important is taking those social network analysis variables and pushing them to the next level. So we've been working with combining social network analysis with traditional regression modeling. And I'm going to talk a little bit about both of those pieces and some challenges that we've had with that, lessons we're trying to learn, and would love to hear from you all any ideas that you might have as well. So the questions that we've really been trying to answer here are, how have population health systems changed over time, and what characteristics of the community really influence network structure? So what I've put together here for you guys is a little bit of a logic model to help you understand how we're thinking through this. So we know that there is a whole gambit of community characteristics: socioeconomic, demographic, what exactly does the healthcare system look like, who are the providers, and what's going on there that then are going to influence how that network is structured. And primarily here we're looking at 4 network variables, and I'll define these in detail for you all shortly, but we've got degree centrality, betweenness centrality, density, and degree centralization. That network structure then impacts the provision of population health activities, which we hope ultimately impacts population health outcomes in the community. So the data used here, we're using the National Longitudinal Survey of Public Health Systems. This is one that's housed in the Systems for Action Research Center, a data set that's collected there. It's a cohort of 360 communities with at least 100,000 residents. So we will talk about this in more detail later in the presentation, but this sample was expanded in both 2014 and the most current wave, 2016, to include rural communities, which is awesome and gives us some more power. But for the purposes of this study, I really wanted to be able to look at it longitudinally in the 1998, 2006, 2012 samples as well. So for that reason, here we still are restricting it to those communities that serve at least 100,000 residents. Like I mentioned, we have waves collected in 1998, 2006, 2012, and 2014. Just want to go ahead and let you guys know that we do have 2016. Our team is actually wrapping up that data collection, and we're excited to have another year to include into this sample and give us a little bit more power. So in the survey, local public health officials report on a few different dimensions. So scope is the availability of 20 recommended core population health activities. Network is the organization contribution to each activity. So they ask about which organizations in the community are helping to provide these. Centrality of effort, so we ask which activities are contributed by the governmental public health agency. And then try to get at quality a little bit, so we ask about the perceived effectiveness of each activity. So we then take the NLS-PHS data and we link it with a couple of really useful sources. So we get information on local public health agency and system from the National Association of County and City Health Officials data, and we try and pull in community characteristics, and these typically come from both the census and the area health resource file. So the analytical strategy we've used here is longitudinal observations of cross-sector participation in population health activities, coupled with multivariate regression for panel data to estimate the associations between network structure and socioeconomic, demographic, and healthcare delivery system characteristics. So a little bit about the network variables that we're using. So we look at it 2 ways. We look at some whole network variables, and the 2 that we focus in here are density and degree centralization. So density is measured by taking the proportion of relationships that exist in the network to the total possible relationships that can exist between organizations. So a network with perfect density would be one where all of the different organizations are working on these population health activities together. We also measure degree centralization. So this measures the connectedness of organizations in the network as a whole. So if you think about a high level of degree centralization, this would indicate that the bulk of population health activities are being provided by a select number of organizations. So I always think about a bike wheel with spokes. So someone in the middle and a few people working together, that would be a high level of centralization. So a little bit on these network variables. So we use the NLS-PHS data and tweak it a little bit to be able to generate these networks. So we calculate it using survey data on the strengths of those ties between the possible pairs of organizations. And that connection is defined as the proportion of those 20 population health activities that are jointly contributed by each pair of organizations. So it's a little bit different. We're trying to make it work with the survey, but we have some plans on doing some more traditional social network analysis, data collection methods that I'll talk about here toward the end of the presentation as well. So some of the organization variables we look at degree centrality. So this counts the number of connections an organization has with other organizations in the network. So a high level of degree centrality might be an indicator of organizations that are actively seeking or being sought out to be involved in population health systems. And we also look at betweenness centrality. So this captures the extent an organization lies between other organizations in the network. This is often referred to as a gatekeeper position. So organizations with high betweenness centrality might be holding important connection positions and play information sharing roles and can be very important in the network. So the analytical strategy, to continue with that, are primary dependent variables. So we looked at two different models, and we looked at network density as an outcome and network degree centralization. And we pulled in just a few of those community characteristics, as I mentioned. So this is by no means an exhaustive list and is largely based on trying to think through this model and what factors might influence the network connections, but also just in general what data we have available at the time. So to start, we've put in population size, whether or not there's a board of health, income per capita, the portion of the population with a college degree, the portion of the population that's non-white, the number of individuals that are uninsured, the portion of the population over 65, and then just a few healthcare system availability measures. So MDs per capita, hospital beds per capita, and whether or not there's a federally qualified health center in the system. So some descriptive data for you guys. What you're looking at here are the average network measures. So in purple you see average network degree centralization, and in green you see average network density. So we see in general that in 2006 there was a bump across both of these, and a large part this can be explained by preparedness funding, and we'll talk about that in more detail. And we see that starting in 2012 and 2014, these track together pretty well, not a lot of changes between those 2 years. In general, except for 2006, networks tend to have a higher degree centralization score than they do density score. So some measures on individual organizations, and this is something that we really wanted to dig into with this data to kind of understand how these different sectors are working together, who's participating in these systems, and how has that changed over time. So just a few things that I really wanted to point out for you all, and bear with me because I'm going to try and use the feature on the program that lets me circle and highlight some things, and remember that I'm a researcher, not an artist. So, of course, the local health department, pretty typical that they rank very high in these. They are connectors in the system. They are our primary providers of these population health services. As I mentioned, in the green here, you can see the general spikes in 2006. We kind of hypothesized that in part that was because of the influx in preparedness funding that came after 9/11. So you saw a lot of these organizations working together for preparedness goals, and you see it back off in subsequent years, in 2012 and 2014. But just some interesting things that I wanted to note. So we see that hospitals in general are one organization that's played pretty central roles in our networks over time, and increasingly so in recent years. We also see local agencies. So one limitation with this data is that is just a general category for all of these. So local agencies, we don't really know what it is, but hypothesize that these are a lot of your social services agencies. Similar with hospitals, we can't determine what type of hospital they are. This is just a bucket. So we see a lot of nonprofit organizations playing central roles. Schools as well, another provider. And really interestingly, we've seen insurers have a bump in their numbers in the last couple of years as playing central roles in these population health networks. So when we look at Betweenness centrality, so remember these are our gatekeepers, or the people connecting a lot of our organizations. Again, not surprisingly, we have the local health department playing a really strong role in this. We also have hospitals having high Betweenness centrality scores, as well as state agencies. Nonprofits are decently high compared to their counterparts. We've seen a bump with community health centers in recent years, and really when you look comparatively, because in general there's pretty low Betweenness centrality scores aside from hospitals, state agencies, and local health departments, you see a pattern as well with both schools and universities. So some interesting pieces about these different sectors and the way they're changing, and we are just looking at average tendencies here, and that's one next step is we want to dig in to each of these individual sectors and really look at what's going on with those relationships. So something else that we see in the data, I pulled out and created some two-way scatter plots of individual organization degree centrality for local agencies, so kind of more thinking about those social service pieces, nonprofits, hospitals, and insurers. And what we see here in this data is that there's at least a general trend toward a positive relationship between the centrality of these individual organizations and the total portion of activities that are being provided in that system. So what you're seeing there on the bottom axis is that bundle of population health services. So we see in general that as these organizations play more central roles so that they're participating in more of these activities, we're just getting a larger scope of activities in these communities. And what you can see here is that that appears to be pretty strong, especially for local agencies, nonprofits, and hospitals. While it exists for insurers, you can see that for the most part down here, it's not as strong as a relationship, even though it's positive, as it might be with some of the other organizations. So again, like I mentioned, some interesting patterns that we really want to dive into and understand more about what's going on here and driving these relationships between those network variables and what we're getting in these population health systems. So the regression results, what you guys see here are both density and degree centralization, so our dependent variables, and then the list of independent variables. So these are preliminary. I want to say that by no means are these the final models. We're just trying to understand what exactly is going on in these communities and found some pretty interesting things. So we see that both population and Board of Health have highly significant, strong, positive relationships with these variables. The population variable isn't very surprising to me, so you think as the population grows, there's just going to be, in general, more organizations available to work with, so that's going to increase density and degree centralization, I think, with both of those pieces. And we're going to talk a little bit about, remember, these are two different variables, but very much so being influenced by the same thing, and what does it mean based on density and degree centralization, and when you have one, do you need more of the others? That's something else we're trying to figure out. We saw that income per capita has very, very small coefficients, was negatively and marginally associated with degree centralization. So as income per capita is going up, centralization, so somebody holding the control of the bulk of services in the system is going down. Portion of the population with a college degree wasn't significant for either of the dependent variables. The portion of the population that's non-white was both negative and highly significant for density and marginally significant for degree centralization. We saw a similar pattern with the number of insured. It actually was not significant with density, but was with degree centralization. And I think that there's some interesting implications for some of these variables, because we think about these as indicating populations that have higher need, are often faced with health disparities, and I think that that leads us to need to think about the system and people coming together, but at what point do people coming together have to back off of that to really focus in on high-need populations. And those are some of the patterns I suspect that we might be seeing here with the data. The portion of the population over 65, we see that as being significant and positive with degree centralization. MDs per capita, although it has a very, very small coefficient, was highly significant. It was positive with density, so the more MDs you have in a system, the more connections you have going on in the system. And it was negative with degree centralization. So the more MDs you have, the more diffusion and control of the services. The federally qualified healthcare center, so it was not significant, but with a negative coefficient on degree centralization, and was marginally significant with a pretty large positive coefficient in terms of density. So if there was a federally qualified healthcare center, there were more relationships being operationalized in that system. With hospital beds per capita, again, very, very small positive coefficient, but highly significant with both of these variables. So what does this tell us? And like I said, this is just the very beginning of trying to dig in and figure out these relationships and understand what community characteristics are driving network structure. And I think that it does tell us there are associations between network structure and socioeconomic, demographic, and healthcare delivery system characteristics. So that really strong positive relationship with the Board of Health is really interesting. It makes me wonder, are they a convener and a coordinator? Are they bringing organizations together to work on these activities, but also perhaps thinking about who's in the best position to coordinate that network and hold the bulk of those activities with that high degree centralization score? We do see the negative associations with characteristics that typically indicate populations faced with greater health disparities. As I mentioned, this may show us a little bit of network constriction. So when you have organizations trying to meet the needs of these populations, they may be focusing in very intensely on certain services rather than that broad scope and package and thinking about what they need to do to meet the services of the people coming to their doors versus talking to the other sectors in the network and how they can work together collectively to help these populations. And this is something that I think we need to dive in deeper and better understand what exactly goes on. And with this survey, that's one thing we can't get at is the intensity of those services. We just know that they're happening. We're not knowing exactly how they look in each of these networks and whether in part they're being ramped up to meet the individual population subgroup needs. So, and really I think that what we have here leads to more questions. So what are the costs and benefits to working across sectors when we see some of those negative relationships? And how can communities that are trying to meet the complex needs of individuals with unmet social and medical needs be incentivized to work collaboratively? So like I mentioned, if they're just trying to focus and constricting that network, what can be done to help them think about that broader array of actors that may be able to help and decrease some of that burden on individual organizations? And I think we need to think about it both organizationally and financially, what mechanisms can be put in place to help us think about cross-sector collaboration and the benefits of that versus the cost. And this is one thing that, you know, we're trying to dive into, and Dr. Danielle Varda, my postdoc mentor, is really working on this, is the cost of collaboration, and these are both monetary and time, and really important to think about as different funders and governmental organizations push for collaboration. It needs to be done thoughtfully and with consideration of what's truly being asked of these different organizations across the sectors. So some of the next steps, as I mentioned, we now have the expanded sample from 2014, and we'll soon have the 2016 sample with rural communities. We want to dive in and understand what's going on there. So rural communities are very different from these jurisdictions that are serving 100,000, and there's a lot more pressure on them because they're facing multiple levels of disparities. So we want to understand what the networks look like there and what the differences are and what implications that has for both their health outcomes, but ways that collaboration can be incentivized. We hope to add in more S&A variables. So we talked about very few today, and there's a quite large gambit that we could pull from that can help us understand these relationships in better detail. And we want to explore that relationship between density and degree centralization. So what I've mapped here for you guys is a scatter plot with density and degree centralization, and we do see that they have a positive linear relationship, and we want to better understand what that means. So when you have a lot of organizations working together, so you have a high density score, does that mean that you also might need more centralization, might need more concentrated control in that network to help everybody work together productively, versus maybe you need more diffuse control? I don't know the answer to that, and I think that's probably very individual to certain communities, so we want to dive in and explore that a little bit more in this data. So, and ultimately where we really want to go is taking a deeper look at the networks to really understand what strategies for aligning medical, social, and population health services have the largest effect on health and well-being. So, like I mentioned here, we are just looking at average tendencies, and we really need to dive into community subgroups, population subgroups, and really understand what collaborative arrangements look like, what's working where, and in which population groups. And our approach for doing this, so we already have some plans in place to do mixed methods, and with this we're going to pull in Dr. Varda's partner tool, so the program to analyze, record, and track networks to enhance relationships, which will let us get some really granular detail on how these different types of sectors are working together. And specifically when we want to put in some questions that examine the cost versus benefit of collaboration and really understand how these different organizations, different sectors with different missions and visions are coming together to think about population goals and work in positive arrangements to impact the individuals in their community at very different levels. So whether that is very community-wide or thinking about small segments of the population. So with that, I think I'm going to pass over to Anna Goodman Hoover, who's going to provide a little bit of commentary, and then we can have some discussions. Like I said, I really encourage you all to provide feedback and help us think about different ways that we can look at this. This was very high-level, average overview, but I think it's starting to help us see some really important patterns and tendencies where we can pinpoint and dive in and find out some really interesting information about the way these networks are working in population health delivery systems.
Thank you, Rachel. That was fantastic. So before I introduce our commentator for today, I'd just like to remind everyone to please type in their questions in the chat box so that after our commentary and after our speaker gets to respond to the commentary, we'd like to bring up those questions at the end of the webinar and address them. So with that, it's my pleasure to introduce our commentator for today, Dr. Anna Goodman Hoover, who is co-director of the Systems for Action National Program Office, where she helps organize cross-cutting and multi-network research studies designed to evaluate and compare public health strategies implemented across diverse settings. Dr. Hoover is a communications scientist and assistant professor in the Department of Preventive Medicine and Environmental Health, and she conducts research in such areas as participatory communication, dissemination and implementation science, and stakeholder engagement in support of evidence-based decision-making. Anna also serves as a communications director and co-leader of research translation for the University of Kentucky Superfund Research Program, supporting the use of research outcomes at the community, provider, and policy levels. So with that, I turn it over to you, Anna.
Thanks so much, CB, and thanks again to Rachel for such a terrific presentation. It is my privilege today to be speaking for the Systems for Action National Program Office, which is located here at the University of Kentucky. Systems for Action is, as CB mentioned at the top of the hour, a national program of the Robert Wood Johnson Foundation, and we really focus on investigating alignment, collaboration, and synergy across not just organizations within a sector, but as Rachel so well pointed out near the end of her presentation, across sectors. What we're really looking at with Systems for Action is how public health, healthcare, and social and community services and supports can really work together in ways that have ultimate impact on health outcomes. Really looking at how those sectors can work together to create a culture of health in which all Americans are able to achieve sustained improvements in health and well-being. This program is part of the Robert Wood Johnson Foundation's Culture of Health Action Framework. It spins out of that action framework to look at the kinds of issues that we're discussing together. And there is, of course, within that embedded an explicit focus on achieving health equity for vulnerable populations. Within the Systems for Action program, we have already in the first year funded extramural projects that investigate how cross-sectoral alignment and collaboration strategies and the implementation of those strategies can affect vulnerable populations, and in particular low-income families, the elderly, probation populations, mentally ill individuals, and frequently hospitalized Medicare beneficiaries. These are just a few of the vulnerable populations that we have already started looking at. So you may be wondering, how does all of this network analysis about organizations feed into understanding how we can best affect the health and well-being of Americans across the board, and particularly those vulnerable populations? Well, the kind of work that Rachel is describing is really foundational for helping us understand how those partnerships, how those cross-sectoral collaborations can really start affecting service delivery in all three of those sectors: healthcare, public health, and social services and support. We know from organizational studies that capacity is really key for understanding complex problems and for devising solutions to those problems. We don't know what we don't know, right? So what we need are partners who can really bring different backgrounds, different experiences, and different perspectives into a conversation as we're trying to figure out how we can better serve populations to help improve their health and well-being. We need partners who have a different angle on the problem that can help us diagnose the kinds of barriers we're dealing with and develop the solutions for overcoming or moving past those barriers. So Rachel's work, we think, is really important for helping us identify the complex relationships between network structures and services, with really a long-term goal of starting to tease out what are the optimal network structures, what are the optimal multi-sectoral network structures for achieving alignment and synergy and collaboration, and under what conditions are those network structures optimal. So we're really looking at how we can bring organizations from multiple sectors together to really impact the effectiveness and efficiency of delivering specific programs and services, including those that draw from healthcare, public health, and social services, so that we can really positively affect the health and well-being of all populations, including the vulnerable populations I mentioned earlier, as well as other vulnerable populations that we're going to be addressing in the coming years. We're really excited about the preliminary findings Rachel shared, and we're looking forward to continuing to keep you on the line informed about the progress in this work as we continue moving forward. I want to thank Rachel again for her leadership on this social network analysis work. It really is going to be, I think, pivotal in helping us identify how best to align those strategies, how best multiple sectors can collaborate with each other, and what kinds of synergies we can really capitalize on together as we begin trying to figure out where are the challenges, how can we overcome them to make sure that we're building a culture of health nationwide. So we hope you're as excited as we are about this work. Thanks again to Rachel, and my thanks to CB, and I'll now turn it back over to CB so we can open the floor for questions. Thank you.
Thank you, Anna. And again, I'd just like to remind everyone, please type in if you have questions, please type them in the chat box. And if we don't get to them, you can always either direct the questions directly to Rachel or email them, or you can also course it through the center and we'll forward it to Rachel too as well. So before we get to the questions, Rachel, would you like to respond to Anna's comments, or if you have anything else you wanted to add, or I'll give you sort of this time first?
Sure. No, I think Anna really summarized it well, and where the National Coordinating Center is going and thinking about this and understanding how we can really use these network analysis tools very powerfully And one thing I will mention, I think I zoomed past it, but we do have a project update page set up around this work. And of course, as always, you put a presentation together and then send it in and think about 5 different things that you could have included to make it better, is pulling out some of those pictures of network structure for you all. And I think that I may run some of those and kind of update the presentation and put it on that page if you'd like to look at that, to have a little bit of an example of what some of those different structures look like. So a network with really low density, or a network with a high degree centralization. So I think that visuals are always very helpful with that, and I apologize for not thinking of popping those in there before I turn my slides over. So like Anna said, really our next goals are thinking about how we can use this network analysis and understand 2 pieces. So really, how are we helping and improving health outcomes in populations, especially those vulnerable populations? But I think that we also need to use it to think about how we evaluate these partnerships and help communities and collaboratives better understand the ways that they're working together. So I see those 2 pieces really being instrumental. And with that, I see a question here that fits this nicely. So Martha Meyer said, how will you measure population health impact? Does connectivity and or density change health outcomes? Martha, this is a really great question. So I think that depending on the individual perspective and research question that you're asking, there's different population health outcomes that you can think about that you would measure. So one thing we use a lot is CDC data on general preventable mortality. So when we're thinking about the community as a whole, you might dive in there and look at that. And that's one that Glenn Mays has used a lot, and most recently has put a paper out in Health Affairs that looks at a comprehensive system and what impact that has on health outcomes. So I think that that's one, if you're looking at the whole community together and trying to figure out what this whole network is doing. So another possibility that I've been looking at, so as Anna mentioned, we're trying to understand these vulnerable populations. So we are trying to think about how do we look at their health outcomes individually and these networks. So specifically there, I've been looking at how hospitals, social services, and public health work together. So the outcomes that we're looking at there are things like hospitalizations and readmissions. So I think that there's a lot of flexibility in that. I know that's not a very specific question answer, but I think that's what's neat about these different methods, is that you can use them in different ways and look at many different outcomes. I do think that those connections do matter. One of the challenges in looking at that analytically is we know that there are a lot of unobservable factors going on that impact both health outcomes but also network variables. So that's one thing with these models. Even though I've got a lot of community characteristics in there, I think that there's a lot more that could go in as well. So that is a little bit of a challenge that we're trying to work through and understand, like I mentioned, how we can use these network variables in traditional regression. So really great question. Thank you for asking that.
So Rachel, Mark has a question just regarding the presentation. Why was 2006 such a strong year for degree centrality? Would you want to answer that question?
Sure. So I think I glazed over it briefly. We kind of hypothesized, because in general in the data, and I might slide back and just pull back up one of those slides for you guys. We see, okay, we'll keep going. So we see spikes in 2006 across the board, and this is where we suspect preparedness funding after 9/11 really came into play. So we know there was quite an influx of it to local communities, and quite a different across sectors in those communities. And we think that probably has to do with the ways that they were working together in services at the time. Not 100% sure of that. Of course, we'd have to do some different analysis looking at shocks to the system like that, but our best guess is that was the shock to the system in 2006. Then again, between 2006 and 2012, you had the recession, so maybe it looks really steep based on a significant drop-off in 2012 because we know a lot of organizations really were constricting their networks to kind of conserve funds and think about doing the best they could in that recession environment. So I hope that answers the question some.
Yeah. So Rachel, Rani has a comment. Perhaps this work has already been done or is being planned, but it seems that considerable qualitative data on what the experience of providing and receiving healthcare is like on the ground would greatly benefit the understanding of the data informed future inquiry. So would you like to respond to that comment?
Yes, that is something. So as I mentioned there at the end for next steps, I really, really want to do a lot of qualitative data collection to really understand these networks because these are average tendencies in the quantitative data, and I think that these arrangements do look very different across communities in subgroups of the population, and I think that it's going to be instrumental for us to think about qualitative data mixed with this quantitative data to really understand what's going on and help us think about making recommendations. I would struggle with even making any recommendations off the quantitative data with the knowledge that every community is very different. And the way I view this is thinking about what we find in these relationships more as a template and being able to help guide communities to use that template in forming their collaborative arrangements. But I think that is a great comment and something that we are definitely trying to move forward with incorporating with this research.
So Mark mentions that they are a rural Robert Wood Johnson Foundation Culture of Health prize-winning community, and they suspect that their degree of connectivity and trust is a strong factor in what they've been able to accomplish together across organizations and sectors. So their question is, how can they, quote-unquote, raise their hands for, I guess, undertaking social network analysis in their community, or at least learn to do it themselves? I mean, are there resources that they can learn from, or how to apply it, I guess, or toolkits or toolboxes that they can use?
Yes, Mark. So I mentioned briefly the partner tool. So this is run by Dr. Danielle Varda out of the University of Colorado School of Public Affairs. So this would be the perfect thing for a local community to be able to use and really help you all understand SNA and use it. It measures trust. It measures connectivity in a few different dimensions, so I think would be really useful for what you all are trying to do. I think that I can make sure that either in the chat box or in something that is sent out after the presentation that I link you to some resources on that.
Excellent. So I think we have one more question in the queue, and that's from Chris. Rachel, can you speculate on what types of networks that you are studying that best contributes to employing system approaches to population health in contrast to, let's say, delivery of services?
Right. So I think I understand what you're getting at, Chris, and if I start going in a direction that's in completely left field, definitely throw another flag up and let us know that. So this is one thing, and I think she's logged on. So we originally were going to have Danielle Varda as a commentator, and she had a conflict, but this freed up. One thing that I think we really need to start thinking about is from the public affairs perspective and really pulling in these nonprofit organizations, because I think that a lot of our conversations center around both traditional public health and traditional healthcare systems, and we talk about them integrating with these other types of services without ever bringing those organizations to the table. So I think that these systems are used to doing some of this really on-the-ground, tough work in these very vulnerable populations. They've got great connections with them. Again, I'm going to say this depends community to community, but I think that they may be better poised with some of these systems approaches in terms of direct delivery of services. And I think that we need to become better in tune to what they're doing and pull them in at the front end of these conversations rather than leaving them out kind of in the back end and talking about them as being tangentially involved. Yes, we need to pull them in and them there at the table from the beginning, which is a really important concept in networks in general, is making sure that you're getting people together and on the right page from the start.
Actually, there's one more question, Rachel, and thank you, and it's from William. And I guess you mentioned a little about this. Are there medical schools and schools of public health included in the university and schools category, and have you assessed if they have particular effects on collaborations and outcomes?
Sure, this is a really good question. So they are included in that category. It's not something that we've dug into individually yet, but it's something that we are interested in. So in some previous research that I've done, I can tell you that we found that overall package of 20 population health services in the community, so the higher the involvement of universities, the lower that package of services. Not really sure about that. I can say, anecdotally here in Kentucky, sometimes the university gets the rap in the state as the ivory tower that just comes in to do their research in our communities and then leaves. So I think that there's probably some effects there going on, but I think that it's something that we really has evolved and we need to take a deeper look at. In particular, I think K through 12 schools are incredibly instrumental in these networks and the services that they provide to students, and we've got to consider that in that full package in more detail as well. So like I said, the thing about this research and what keeps me going is that every question I feel like we get a little bit of an answer to, as you all have done so well asking here today. I think we get about 100 more questions with what exactly is going on in these networks and these organizational relationships and what it does to outcomes in those communities.
Rachel, if you don't mind, this is Anna. I just want to jump in really quickly because I think this is a good moment to mention to folks that in addition to that project page on the systemsforaction.org website where you can follow along with this work as new products become available, also those of you who are interested in specific questions like we just heard about what data are gathered might be interested in looking at the page dedicated to the National Longitudinal Survey of Public Health Systems. From that page you can link to the survey instrument for 2016 and see exactly what kinds of questions are being asked. You can also find a little older public use data links and blogs and all kinds of resources related to the survey and how it's being used in the intramural research at the National Coordinating Center. Rachel has obviously led a chunk of that work. CB is leading some of that work. Dr. Glenn Mays is leading a lot of that work. So I really recommend that as you visit the systemsforaction.org website and check out this particular page, that you do some exploring and have a look at the instrument and some of the other pieces as these kinds of questions that William just asked occur to you. Thanks.
All right, Rachel, any last words?
No, I just want to thank you all for being active participants today and giving us some really good questions, and I think that we've got some more work to do and to think about, and I hope that you guys will stay engaged with us. Definitely, as Anna said, check our pages, check my update page. Please feel free to reach out to me. I'm hoping to keep this going, and I love getting commentary and feedback because I think it helps make it that much stronger.
Well, thank you, Rachel. This is a great way to end the year with your fantastic presentation. And while this year's series of Research in Progress webinar series has come to an end, we do invite you to take a look at our upcoming webinars for next year. And just like with this webinar today, all our past webinars are available for download. So we do invite you to take a look at our Systems for Action webpage. And I guess with that, we'd like to thank again our speaker, Dr. Rachel Hogg Graham, and also our commentator, Dr. Hoover, for your time this afternoon. We would like to thank everyone also for joining us this afternoon too as well. So we wish everyone a Merry Christmas, Happy New Year, and we hope you have a great day today. Take care. Thank you very much for joining us.
Thank you, Rachel. Thank you, CB. Thank you, Anne.